Hello, everyone, and thank you for joining us for our breakout session on comfort care, hospice, and end-of-life consideration in FTD. We are going to get started so we can use the full time for this helpful and informative session. My name is Stephanie Quigley, and I'm the helpline manager with AFTD. This session will be recorded and available on our website after the conference. Participants will be muted for the duration of the presentation, but can submit questions in the live discussion pop-up. Click the questions tab and where it says ask a question, you can enter your question there. Dr. Gallagher won't be reading the chat coming through as she is presenting, but AFTD staff are behind the scenes to help and share questions at the end as time allows. As always, our helpline is available after the conference to discuss any individual situations. You may also find some resources in our booklet and on AFTD's website. With that, welcome again. It is a pleasure to introduce Dr. Maribeth Gallagher, who will be presenting on comfort care, hospice, and end-of-life consideration in FTD. Dr. Gallagher is a board-certified psychiatric nurse practitioner with a doctoral degree in nursing. She serves as the director of Hospice of the Valley's Dementia program and has received national and international awards for its innovative approaches to dementia care. Her commitment to improving dementia care was initially inspired by her own experiences as a family caregiver, sharing her journey with her loved one with dementia from diagnosis to death. It is my pleasure to welcome Dr. Maribeth Gallagher, who will take it from here.
Thank you, Stephanie. Welcome, everybody. Thank you so much for being here today. So here are the goals that we're going to discuss today about hospice, what comfort care principles are, what are the benefits of hospice, what are the special considerations for people living with FTD, and let's definitely dispel some myths. I don't have any disclosures or conflicts of interest. And, you know, if I have seen further, it is by standing on the shoulders of giants. And I just want to remember my dear colleague and mentor, Dr. Jerry Hall, who died this year, who has been a fierce advocate for people living with FTD and for their care partners for a very, very long time. Dr. Hall and I started, we co-facilitate an FTD caregiver support group for at least the past 13 years, and the work continues on, but I am forever grateful for all that she has taught. So as you heard this morning from Dr. Bruce Miller, you know, there's a lot of hope about finding treatments, but for right now, we need to work with reality as it is. There's a saying that says, cure sometimes, treat often, and comfort always. And so that's what we're going to be focusing on today, on people in the advanced and end-of-life stages of FTDs. So the different types of FTD symptoms, they look differently in the earlier stages, right, of these conditions. But regardless of what, and they progress in unpredictable ways at unpredictable rates. But regardless of how dissimilar they may look up in the earlier stages, by the time we get to the advanced and end of life stages, individuals, regardless of the variant of FTD that they have, will look more similar than differently. And ultimately, they will require total care. And I'll unpack all of these as we move forward. I want to set the stage by making you aware of something if you're not already. Most adults report, and this is based on research of people with dementia, not FTD specifically, but most adults report that they wouldn't want aggressive medical interventions if they had advanced dementia, right? So if they're in the advanced stage by then, their choices would be that they wouldn't want their dying prolonged. They'd be saying things like, keep me safe, keep me comfortable. When it's my time, it's my time. Then studies ask the proxy decision makers, the people who will speak on behalf of the person in the advanced stage of dementia, what is the most important focus of care for the person when they reach the advanced stage? And most proxy decision makers say comfort. So you're hearing this theme, aren't you? And yet when we look at the literature, we see that people with end stage dementia, and again, this is in general, not specific to FTD, but they have fewer completed advanced directives. We're going to talk about that because this guides all of the decisions that are going to be made. And there are some serious decisions to be made. Also, this population tends to have more distressing symptoms for which there are absolute treatments where we could help the person feel so much better related to pain and eating problems, neuropsychiatric symptoms, infections. Individuals with end-stage dementia, as compared to other people their age, tend to have more costly and burdensome interventions that offer little to no clinical benefit. In other words, a lot's going on to the person, and yet it's causing more suffering with no beneficial payoff. Individuals with end-stage dementia also tend to have more avoidable transitions of care to the emergency departments, hospitalizations, and when they're in the hospital, they're there for longer. And interestingly enough, whether they're hospitalized or not, they tend to have higher mortality rates after the hospitalization. So I present this information to you in order to pose the critical question: how do we bridge the gap between the care that people say that they want and the care that they tend to be actually receiving? The strongest and most consistent modifiable factor to answer that is that we really need to have more discussions around advanced care planning and complete the advanced directives. And it's never, ever too early to start these conversations. We want to have them with the people living with dementia so that they actually will be able to participate in giving voice to how it is that they want this to unfold. Also, it's going to provide the care partners with reassurance that they're making the right decisions. And it also will help all of us as healthcare providers in doing what's right for you, because there's no right or wrong answers per se in the choices. It's what's right for you. So when we talk about advanced care planning, this isn't a one-time discussion, all right? Please know that this is a process. This is an ongoing conversation where we're going to help you make informed decisions, right? Not just say, what do you want us to do? That would be an awful thing to pose, but instead say, here are the options of where we're standing right now, and here are the pros and cons to those options. And the choices that are made in a mild stage of dementia are often quite different than the choices that would be chosen in the advanced stage or at end of life. So it's so very important to have these conversations and to initiate them yourselves. In case you're waiting on the healthcare provider, that might not happen. So it's very important for you to be an advocate. And then the advanced directives, the legal documents that express the type of medical care that you want in the event that you can no longer speak for yourself. And these aren't written in stone. You can absolutely change them as time goes on if you want. So let's meet Don. Don was diagnosed with behavioral variant FTD at age 58 at a memory clinic. And Don lived at home with his wife, Linda, for the next 4 years. But over that time, Don's symptoms continued to worsen, and he became increasingly dependent on Linda's help for all of his care needs, all of his daily activities, and to keep him safe. But in spite of her best efforts, Linda developed health issues on herself and couldn't any longer take care of Don in the home. And although she really didn't want this to happen, Don eventually had to move into a memory unit. In spite of Don's good care at the memory unit, as time progressed, because he has a progressive neurodegenerative condition, his condition declined. And so this is what advanced stage FTD usually looks like. And this was what Don was showing. He became completely dependent on others for all of his care. He was incontinent of bowel and bladder. He had increasing difficulty swallowing in spite of tips and tricks that we use to try to facilitate successful swallowing. He started to have more episodes of choking. He was eating less. Dr. Bruce Miller talked about hyperorality in the beginning, but now he was eating less, had a natural desire not to eat food, and he was losing weight. He was physically weaker. His gait was more and more unstable, so he required assistance to stand up and to move around, to transfer. He started to sleep more, nap more. He had increased confusion, difficulty in deciphering and interpreting what was going on. His verbal language diminished. He had more and more difficulty understanding others' communication, and he started to develop some infections. So at this point, Linda asked Don's physician to visit Don and to perform a comprehensive examination in order to determine if any of the decline that was happening to Don, if any of those were due to treatable conditions, right? Like dental problems that can interfere with eating, infections, maybe medications that are posing more harm than good at this point, or any other new developing ailments that Don could have. And the physician did a thorough evaluation and didn't find any reversible causes and concluded that, yes, indeed, this was biology taking over, if you will, and Don was moving into the advanced and end-of-life stages. And she suggested at this point that hospice would be good not only for Don, but for Linda and her family as well. And so Linda agreed to enroll Don in hospice services. So what is hospice exactly? Well, it is care that's focused on the whole person, body, mind, spirit, whole person who has a serious illness that is entering into the last 6 months of life. Now, end of life is actually difficult, at least the last 6 months of end of life. For people with dementia, it's very difficult to prognosticate. But we look at the clinical presentation and we make our best guess. The treatments, every bit of focus at this point is focused on comfort, and anything that had to do with curative interventions for maybe some other conditions, etc., all of those are ended. It's provided by specially trained experts, again, who are focusing on symptom management and ding, 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 quality of life. It's provided wherever the person resides. And it's not 24/7 care. Yes, we're available 24/7, but the care is still provided by wherever it is that they reside. Now we can go into the home, we can go into facilities. There is a beautiful presentation on the AFT webinar site, a webinar on neuropalliative care. And I strongly encourage you, if you have not seen that, to listen to Dr. Christina Vaughn's presentation. And she talks about palliative care, which is comfort care that can be given to people at any stage of a chronic serious illness. There's a misunderstanding that palliative care and hospice are exactly the same. Palliative care can be given to people at any stage, but in the last 6 months of life, there's a special type of palliative care, and that's hospice. So that's what I'm trying to do with this visual, is to show you that hospice is a part of palliative care, but a special part. So what does hospice provide? Well, as you can see here, it provides many things. I want to point out in particularly the richness of an interdisciplinary team. The nurses, the blessed CNAs, the wonderful social workers and chaplains, the medical directors, the volunteers who choose to use their life in service to working with people at end of life. All of this is part of what you receive. In addition, if the person's living at home, the care partners are offered respite opportunities for free, where the person can go into a facility while you get, 5 days just for yourself every so often. There's inpatient hospice units because sometimes symptoms get out of control and can't be effectively managed for that crisis period. And so it's better to bring the person into a unit where nursing eyes can keep a 24-hour look on this person, maybe change the medications, and then the person can be discharged to home as well. Also, sometimes families don't want that last couple of days of active dying to be done in the home, that it's just too much. And so the person can come into the unit. They will be skillfully and compassionately cared for. Also, a great part about hospice is that it offers bereavement. So these are skilled grief specialists who for 13 months will help you after the person dies navigate this very tender period. When is it time for hospice? So again, we're looking at that last, ideally, 6 months of life. You don't need to die on time, I like to say to people, because nobody really can predict this. But clinicians have an idea of what this looks like. And so when a physician guesstimates that a person has 6 months or less, this is when hospice is usually recommended. Also, it needs to have the willingness of the person with the condition or their proxy decision makers to want to receive hospice service. And please do not wait for a provider to bring up the word hospice or any kind of discussion on it, okay? Because sometimes families make the mistake of, well, I thought, when it's hospice time, that the physician or the provider would bring it up. And sometimes the providers are going, well, I don't really want to upset the family, so I'm not really bringing up the hospice talk yet. And so everybody's kind of not talking to one another. And meanwhile, you could be missing out on beautiful support. So Let your providers know, let everybody know that when it's time to talk about hospice, that you want to enter into these discussions to at least consider it. How much does hospice cost? Well, it's paid for by Medicare, Medicaid, and most private healthcare insurances. Some hospices, some nonprofits like the one that I work for, no one will ever be turned away for lack of ability to pay. Dame Cicely Saunders said this quote, which I think is really important. You matter because of who you are. You matter to the last moment of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. So people think of hospice and they're like, okay, it's dying. No. For those of us in the hospice world, it is all about living well and fully until you die. And we are the experts who want to help not only the person with the condition, but all of the people around them who are offering support. So the focus is on comfort care, comfort in body, mind, and spirit. And when we look at the research, what are the core elements that help us reach that goal? Well, first of all, we have to identify who are going to be the decision makers who will truly speak on behalf of the individual with the condition and honor their wishes, right? We want to identify those people and we want to get those advance directives written, completed, so that it's going to guide all of the decisions that are going to need to be made as the condition progresses. However, we want to make sure that you're making informed decisions, okay? That you really understand, Dr. Maya Angelou is known for saying, when we know better, we do better. And that's the goal here, is that we want to educate and support all care partners. A great example is, who knew about FTD until it came in your life? And a whole lot of people in the healthcare world don't know about FTD. So education is so important. And of course, support, because this is very difficult and very heartbreaking and scary. So knowing about disease progression, understanding the common complications that arise, because we want you to be able to recognize them in the early stage and call us for assistance, early intervention. Also, what are the common causes of death? From a best practices perspective, there will come a time when simplifying the medications is actually going to be in the best interest of the person and avoiding any unnecessary intervention. So maybe in the early stage and the moderate stage, there are certain medications that they're on, maybe for their lipid level, for blood thinning, for glucose control, for instance, but it's going to get to a point where we have to ask ourselves, we look at each and every medication and say, in the context of the persons in the advanced and end of life stage, are these medications posing more harm or are they still helping? An example would be someone who's a high fall risk. Blood thinners actually pose more risk of bleeding than preventing a stroke. We also want to avoid tests that can be annoying or frightening to the person, tubes that the person's going to pull out, needles. We want to really reconsider all of this. We want to maximize their comfort, of course, with effective symptom management. And so now, because the person can no longer use verbal language to communicate maybe what they're experiencing internally, we're going to switch our focus into really anticipating what are all the things that could be happening for this person that may be causing them distress, and anticipate what those needs are before they need to manifest them or experience them. And we are going to liberalize the care plan now, okay? It is time to party. We want to live large. If all the person likes is ice cream, power to ice cream every morning, noon, and night. Person-directed care, we're going to be watching the person very closely because they're going to be giving us a lot of cues as to which directions we need to take and what's going on. And we want to customize all of the things that bring them comfort, pleasure, meaning, belonging, that come in through the senses. Remember, verbal language may not be working anymore. FTDs are diseases of the brain. They're not diseases of the heart, the soul, whatever terminology you want to give to us that makes us so much more than just the brain. The language of the brain is verbal language, blah, blah, blah. But the language of the heart and soul, you and I will always, and the person with dementia will remain fluent in. And a lot of that information is going to be coming in through our presence, through the environment, and through the sensory methods and spiritual methods. And so now we're really going to focus in on those. So in the case of Don and Linda, Don appointed Linda as his medical power of attorney and mental health power of attorney soon after his FTD diagnosis, when he could make those decisions. And then the hospice team reviewed with Linda the details of the realistic outcomes that are associated with choices like resuscitation, hospitalizations. Let me give you an example of that. Resuscitation in a person with advanced dementia is 3 times less likely to be successful as compared to another person their age. The rare individual who is resuscitated will more than likely die within the next 24 hours, intubated and restrained in an intensive care unit. Most people don't want that. So that's why it's important for you not only to make decisions related to these types of decisions, but to have informed decisions on what does that look like if I choose yes or no for a person with advanced dementia. Another example, feeding tubes as it pertains to advanced dementia pose no benefits and actually pose risks of infection and the person pulling it out. And then, when someone has a fall with a significant fracture, maybe in the early stage, you would say, yeah, let's have that repaired. But with a person with advanced dementia, oftentimes this doesn't prove to have beneficial outcome. Many of us know the story. He or she was doing pretty well with dementia until they broke a hip, and that was the beginning of the end. That's when things were expedited. So these are the kind of conversations that you want to help inform you. So with Don's advanced directives, Linda chose allow natural death because she knew that Don didn't want to be resuscitated in the advanced stage or to be hospitalized, have feeding tubes, to receive antibiotics or any unnecessary interventions that would prolong that terminal stage. He wanted all care to focus on keeping him safe, comfortable, and helping him optimize his level of well-being, meaningful connection as long as possible. And this is critical because we are the people who will determine the quality of life for a person with advanced dementia. One of the easiest ways that we can do this is to customize the care to the individual who can no longer speak to themselves. So there's lots of forms like this. We developed this back in 2005 of what is important. Where's the person from? What is the music that they love? What are the smells, the tastes, the forms of touch? When I remind the person of who they are, this is saying to love a person is to learn the unique song in their heart and to sing it back to them when they have forgotten. So I want to be able to hold up the mirror and show you how magnificent and how loved you are. And so we use this information to celebrate the whole person. There's still a person inside, right? And now we need to find ways to transcend the boundaries that are imposed by the disease itself. I want to give a special shout to pain and dementia. It's often under-recognized and undertreated in people with dementia. We can ask them if they have pain. They may respond no, but it may not be a reflection of their internal true experience. There's a tool called the PAINAD. Just write that down and look it up, which allows us to use this our observation to look for the signs and symptoms that may indicate a person is experiencing physical discomfort. And oftentimes we don't want to use as needed pain medications for a person with dementia. We want to start low with something with Tylenol, acetaminophen, and give it to them routinely. PRN is the medical way that we write out use as needed. And in the world of dementia, we sadly say that oftentimes it stands for patient receives nothing when it comes to pain medication. So we want to make sure that they receive it routinely. So Don's care based on his end-of-life wishes was revised. His medications were simplified. His diet was liberalized. We were offering him his favorite foods all throughout the day. Not, Don, do you want this? But have a bite of this, it's delicious, with something that we knew he liked. We'd offer it to him, but if he turned away or didn't want it, we didn't force it on him. He was closely monitored for any signs of distress. We tried to anticipate all of his needs so that all of his needs were met. We offered opportunities throughout the day for him to experience meaningful connection with others. You and I, without any words, we can sit next to each other and hold hands and listen to music that we love, or look out in nature, or to hear prayers, or to smell delicious smells, or just to be snacking on something. And even though no words are happening, there is this shared sense of intimacy. And so we do this even at end of life with people. And we tailored all of the knowledge and the skills and the support that Don's family and the facility caregivers needed to really individualize the care for Don. Examples again, that we educated them on what to look for as Don declined. We did frequent check-ins with everybody to make sure we were staying on top of things. The CNAs were going in and bathing him while playing music and being very gentle with movements and keeping him from having to move into fearful or resistive behaviors. We were modeling all of the techniques that we use in that advanced stage in order to teach people. Linda was attending our FTD caregiver support classes and also was starting to understand this very complex grief called ambiguous loss. Pets visited, chaplains, and they received supportive equipment like the hospital bed and incontinent briefs. The most common causes of death for people with dementia are usually associated with eating difficulties and decreased nutritional intake, infectious episodes, aspiration pneumonia being the number one. And again, like I said earlier, falls with fractures. Back in 2011, I reached out to with the experts at that time across the United States and asked them if they would contribute what they thought were the red flags of people moving into those end-of-life stages. And so this is a synthesis of the information that you can find in the FTD Partners in Care Fall 2016, and also on my webinar from 2011 on the AFTD website. So there's no formal criteria to prognosticate the last 6 months of life for a person specifically with FTDs, but the severity of the dementia is usually the greatest predictor. And over here, as you can see in purple, when the person's requiring total assistance and care, when they're having difficulty with swallowing, chewing, pooling of food, we know that this can increase the risk for aspiration pneumonia. Severe language impairment, the immobility is posing risks of tissue breakdown and blood clots. Incontinence can lead to more infections. The frequent falls can lead to just a number of things. Weight loss and any signs of motor neuron disease, like in the FTD 101, they were talking about fasciculations, which are these waves that happen underneath the skin that we look for. In Don's final 6 months, he was napping more, sleeping for longer periods of time. He was limited to the bed or the chair. He stopped speaking. He had very little interest in food, and he had more choking episodes. And in his final days, he did indeed develop an aspiration pneumonia. The hospice team was offering 24/7 support because this is a scary and emotional time for everybody involved. We monitored him very, very closely for any signs and symptoms of distress. We played his favorite music. He loved the smell of orange blossoms. We had that in the room. Linda was gently stroking his hand and moistening his lips when they seemed dry. And because hearing is one of the last things to go, she was just always expressing his love, how much he was valued. He died comfortably with Linda present, and Linda participated in the 13 months of bereavement afterwards to help her through that very difficult time. This slide is telling us about the benefits associated with hospice when it's provided by dementia-capable hospices, which not all hospices are dementia-capable. As you can see here, the things that stand out to me is more effective symptom management, and that families perceived higher quality of care and also higher quality of dying. So there's hospice eligibility criteria for dementia. It is very difficult to predict that last 6 months again. But here, just as you saw illustrated in Don, are generally the components of that criteria. Now, let's focus in on people who have FTD. Barriers to hospice. Many people don't understand FTD as a terminal condition. Accurately predicting end of life is difficult in dementia anyway, but particularly for people with FTD, because the hospice eligibility criteria were based on Alzheimer's disease, and as you know, can be very different. Also, people with FTD are generally younger. They look more physically robust. They still look good, so to speak. They don't have the chronic comorbidities that other folks who are older have. And they may still walk, even though they're high fall risks. So they're just not fitting the clinical picture, are they? Hence, it is so important for every single one of us to use our voice. We have to be fierce advocates, because if we're not, people with FTD and their families are not going to receive that timely access and all the benefits that you are entitled to through hospice care. Also, please ask whoever's filling out the death certificate, to put the FTD, at least FTD, if not the subvariant diagnosis, because in data collecting, we're just not capturing this. When we think about considerations for choosing a hospice for persons with FTD, I know this slide is busy. If you go to the Partners in Care Fall 2016 on the AFTD website, all of this information will be there. But you want to ask the hospice, so do they have experience with people with FTD and their families? Yeah? Okay, what have you learned? How do you determine FTD hospice eligibility, knowing that they don't fit the profile of people with other forms of dementia? Is the hospice available 24/7 by phone, including weekends and holidays? If an emergency arises, will somebody get out there in order to help you and help the staff if they're in a facility? How long will it take for them to get there? If my person's at home, do I get a different type of hospice care, meaning the number of visits as compared to if my person's in a facility? Will you train me, and will you train the facility so that they know how to do this well? All of these types of questions are so important. And also, what about if they need to help you with facilitating brain donation or brain autopsy? Will they help with that? And then, of course, double check about, costs and insurance and all of those important issues. Okay, common misconceptions about hospice. All hospices are the same. They are all part of one organization. No, just in Phoenix, Arizona, where I am, there's over 200 hospices, okay? Not all hospices are the same. A hospice is a place where you go to die. Okay, hopefully in something that I've said so far, you're getting the gist that it's about where you go to receive expert comfort care, and our focus is on living well until you die, and then hopefully to help you die peacefully, and all of the people around you to feel that they did their very best. Hospice is giving up or doing nothing. Absolutely not. It's not about giving up. You know what it is? It's about stepping into, it is what it is, right here, right now. Biology is taking over in spite of all medical advances. So how do we shift the focus? And I like to say, do aggressive comfort care. Maybe I'm not doing aggressive life-saving care, but I am doing something, and I'm doing it very skillfully. It's only for the last hours or days of life. No. Remember, it's for at least the last 6 months of life. And if you continue to decline, but more slowly, if we can continue to document that you're declining, you will stay on. Some people think, wait a minute, hospice does dementia? That was my personal family's. We didn't know that hospice did dementia. And hopefully you want to find, again, a dementia-capable hospice who really knows how to do it. It's only for the elderly. No, we do it for infants and all people. You can't keep your own doctor. You can keep your own doctor if your doctor agrees. But some people really like to move in with the hospice doctor, who may have a lot more expertise and focus on symptom management. Once the choice is made, there's no turning back. No, you can revoke from hospice service at any point. Okay. And then you're sort of like, well, we already used 2 months. Does that mean I only have 4 months left in my hospice wallet? No. You have 6 months. And again, that's just a ballpark of what is determined by the true person's actual decline. Hospice professionals hasten death. Look in my face. No. We don't hasten death. We really focus on your quality of life. We really want you to live well. We want to honor you in body, mind, and spirit, and make the sacred precious time of your life, the best that it possibly can be. Not only you, the patient, but of course you, the family, as loosely determined by you. You can bring in all of the family. I never want to give a hospice presentation or a dementia presentation without including the voices of people living with dementia. Nothing about us without us, right? When people with dementia in the earlier stages are asked to describe what is ideal end-of-life care for you, this is what they say. Keep me comfortable. Recognize, evaluate, and treat my pain and all my other symptoms. Okay, so you're hearing comfort again, aren't you? Uphold my dignity. Facilitate self-determination and informed decision-making. Okay, so yes, people in the earlier stages, we do know, we recognize deficits. So we want to keep the person safe. We want to do for them what they can no longer do for themselves. But let us not forget that people also have residual abilities, and we want to celebrate those. And so for as long as possible, we want people with dementia to be making their own decisions, and we want those decisions to be informed, as well as the care partners. Be frank regarding realistic outcomes, right? Tell me the truth. And I want my family present to advocate for the wishes. So again, this is where hospice comes in and really wraps our arms around everybody in the process. And also one of the wishes is please provide skilled palliative or comfort dementia care, right? Interestingly enough, 100% of the people who participated in that study who had dementia, not one of them wished for resuscitation or any heroic measures. Again, this theme, keep me safe, keep me comfortable. When it's my time, it's my time. So what I've been saying to you is, we look at this person who's at end of life and they're in the bed and we're wondering, is there anything that I can do? And it kind of almost is a learned helplessness and hopelessness. But I want to slash that, break the stigma of that there's nothing that we can do. There's always more that we can do. Comfort always, and you don't have to do this alone. Remember that although the higher levels of the brain, the cortical regions, there's a lot of cell death going on. My thinker may not be working, but my feeler is still working, isn't it? And I can experience laughter. I can experience fear. I can experience frustration and rage. I can experience belonging. I can experience reciprocity, that I still get a sense that I matter in your world. And so we want to help you understand those skills and to bring pleasure, which many, many times in advanced dementia comes through the five senses. Remember, some of the last parts of the brain to deteriorate are process music. We have people who can't speak, who can sing, right? All of us have put food in our mouths at certain times in order to make ourselves feel better. And so especially for people who maybe have been limited on what they can take in, it is party time now. We want to move through that day, offering people chocolate and ice cream and whatever it is. I may not be able to understand what you're saying to me verbally, but the squeeze of a hand, the hug, a look says volumes to me, doesn't it? Certain smells, if I can still do that, that if we're smelling fresh grass being mowed, how it's uplifting. Are we using all of the residual abilities that this person has and really celebrating them to the max? My patients have been my greatest and most noble of teachers, and I hope that I'm serving them and communicating to you. Spiritual practices can have a profound impact on a person. And I don't just mean religious. I learned from a farmer that the best thing I could do for him was to get him outside of his house, put his John Deere cap on, let him feel the sun on his face, and to feel, just smell the smells in the environment, put his tootsies in the grass. And that was the best darn medicine that he could have had. So these are the things that we want to focus on. Comfort always. You don't have to do this alone. There really isn't enough time for me to share a lot of the words of the families that we've served, but I do want to bring you back to the AFTD website is amazing. And I really strongly encourage you to watch Dr. Christina Vaughn's Neuropalliative Care and FTD webinar, and to read the Partners in Care on Neuropalliative Care from the winter 2020. Also, I invite you to see the old one, the webinar on hospice care back in 2011, and to read the Partners in Care. So with that, I think I'm going to check in with the chat because I see some things are there, and I'm going to stop sharing my screen.
Dr. Gallagher, thank you so much for this very important information and discussion with all of your wisdom and resources that you have shared. I believe we have time for a couple questions. So the first question that was asked was to please address the antibiotic use at end of life.
Yes, thank you. Okay, so everything depends on the wishes of the person with dementia, how they would want this to play out. But let's say they said in the earlier and moderate stages, if I have an infection, of course, please, treat me with antibiotics. In the advanced and end of life stage, there's going to come a time when those antibiotics, when you start to see infections come back over and over and over again, this is a sign that's saying biology is taking over. Antibiotics, there's a possibility that they may not work. And in addition to it, though, they may be causing distressing symptoms like gastrointestinal upset, like yeast infections. Antibiotics have been, unfortunately, so overused in people with advanced dementia that sometimes we're seeing things like C. diff more often. So we want to use them judiciously. But the reason I said antibiotics is because there will come a time when, more than likely, especially if you're seeing the person's immune system is not robust the way it once was, that these antibiotics may not be working. Oh, and also, please let me say, so aspiration pneumonia being one of the most common forms of death. When aspiration pneumonia is treated by hospice and palliative professionals, we've learned it's one of the most comfortable ways to die. And we watch you for any symptoms like fever or any pain very, very closely. And we medicate you for that. Not so much that we're expediting your death. I don't want you to think that, but that we're looking very, very closely. But I want you to give you a message of hope that this is a very peaceful way for many people to die.
Another question came through: how can families get their loved ones approved for hospice when they are struggling?
Yeah, so that's the whole thing is, unfortunately, it's like tag you're it, depending upon where you are. But remember, you have the AFTD, you have the literature there. It's not your opinion. It's stuff that's on the AFTD. You can use that as evidence and ask the AFTD for your support. Do you want to say anything about that, Stephanie?
I mean, always the helpline. We're here for everybody's situation and can help out for sure. Another question came through as far as when is the ideal time that families should seek hospice?
So have a conversation with anybody who's involved with your person's care and make them read your lips that when it's at all possible time for hospice or even drawing near, it's not time yet, but it could be happening, you want to have the conversations. You may need to remind the person. Also, many hospices like mine is you can call our hospice, if you're in Phoenix, Arizona, and we can come out and look at your person at no cost and determine whether they seem to look that it's time for hospice. And then we can contact the medical provider or give you the words to contact them yourself. So you might want to reach out right to the hospices as well. Hope that's been helpful.
Another one came through: can you get kicked off hospice?
Okay, so here's the deal. Sometimes when people come on hospice and we simplify their medications and really treat the symptoms, suddenly, surprisingly, they look a lot better than they did. And they don't show any further symptoms of decline. So we watch them for a while, but truly, if they seem to be trending up instead of down, because of the criteria for hospice, we will have conversations with you. It won't be abrupt. We'll be giving you these signs. We'll be looking so closely and working in collaboration with you for even the smallest indications that it's decline. If perchance there's not this ability, we'll have the conversation and the person will be discharged for extended prognosis. But we will stay in close contact with you, and you, in case the hospice doesn't stay in close, you stay in close contact with us. And as soon as something changes, and it will, in a predictable or unpredictable fashion, come back on hospice. And then again, it's not like you already used up a couple of your months. You start the whole 6 months process or whatever is needed.
Well, thank you very much, Dr. Gallagher. This has been a great session. In a moment or two, we will automatically leave this breakout session and return back to lunchtime. So thank you all for attending this session, and we hope you have a great rest of your day.